Right. Hi, everybody. Thank you for joining us today. We have Dr. Christine Montross here today with us. She is a 2015 Guggenheim Fellow in Nonfiction, and Dr. Christine Montross is an Associate Professor at the Psychiatry and Human Behavior at the Warren Alpert Medical School of Brown University. She is a practicing inpatient psychiatrist and performs forensic psychiatric examinations. She completed her medical school and residency training at Brown University, where she received the Isaac Ray Award in Psychiatry and the Martin B. Keller Outstanding Brown Psychiatry Resident Award. She received her undergraduate degrees and a Master of Fine Arts in Poetry from the University of Michigan, where she also taught writing classes as a lecturer following graduation. She was born in Indianapolis. Dr. Montross's first book, Body of Work, was named an editor's choice by the New York Times and of the Washington Post's best nonfiction books of 2007, excuse me. Her second book, which is my personal favorite, Falling into the Fire, was named a New Yorker book to watch out for. Her latest book, Waiting for an Echo, was a finalist for the Los Angeles Times Book Prize. It was also named a New York Times book to watch for, a Time Magazine book to read in July, and an Amazon.com Best Book of the Month. She has also written for many national publications, including the New York Times, the New England Journal of Medicine, Time Magazine, the Washington Post Book World, Good Housekeeping, and the Oprah Magazine. Dr. Montross has been named a 2017 to 2018 Faculty Fellow at the Kogut Center for the Humanities, a 2010 McCall Johnson Fellow in Poetry, and the winner of the 2009 Eugene and Marilyn Glick Emerging Indiana Authors Award. She has also had several poems published in literary journals, and her manuscript, Embouchure, was a finalist for the National Poetry Series. Thank you so much for being here today.
I'm really happy to be here. Thank you for that introduction. I appreciate it. And I'm sure we would all rather to be together in person, and I feel like that is on the horizon. So I'm really hopeful that it won't be long, that these meetings continue to be little squares. But thank you for being here nonetheless. I know that Zoom on a Saturday is nobody's idea of a great time, but I'm impressed that you're here, and it's exciting to me to get to be a little evangelical about psychiatry to a receptive audience. I certainly love my job, and so I love to talk to people who are interested in psychiatry. And my hope then for today is that this talk will really be partially a talk and partially a discussion too. So if there, that my hope would be this would be an opportunity for questions to come forth. So I like to do talks a little bit like a literary salon, where I talk a little and read a little, and then would love to have a question and answer period of time where if anybody has questions, we could turn it into more of a discussion, especially with a reasonable sized group like the one that we have. So, one option would just be that if questions come up, you can just stick them in the chat, if that's okay with you, Sarah, and then maybe you could even, I'll ignore the chat altogether, and you could even read me some questions at the end, or people are welcome to just raise their hands and unmute themselves and ask questions at the end as well. So I'm happy to keep it very casual. Okay, so I thought that I'd talk today about how, for me, there have been many opportunities for advocacy in psychiatry, but as Erin said, I was a writer before I was a doctor. So for me, reflective writing was really the place where I had both a personal and a public tool to really better understand the patients that we care for and the illnesses that we treat. And I think one of the things that is just a fact of our world in psychiatry and in medicine these days is we often have such compressed periods of time with our patients, right? So we might have 10 or 15 minutes with a patient, and in that period of time, we have to really listen to what they're saying, and at the same time be thinking through what we think we're seeing, right? Thinking diagnostically about them, and also planning for how we might be able to treat or help the patient that's before us. That's really hard. That's a lot to do in any encounter, and it's particularly challenging, I think, in a field that doesn't have the same kind of diagnostic clarity that a field does where there might be imaging to give you an answer, right? You look at an MRI and you see if there's a growth on someone's lung when they're complaining of shortness of breath. You look at blood work and you can really tell if someone's experiencing hyponatremia, and you know then how to address your treatment. But in psychiatry, really so much is looking at the patient, listening to the patient, and then trying to discern from your own knowledge and your own experience what you think the answers might be. I think that makes psychiatry incredibly rewarding. I think there's a real possibility for creativity and in-depth thought. And indeed, as Darren said, I was a poet before I was a doctor. And I think poetry and medicine have a lot in common, that in poetry, we look closely at things and then draw larger conclusions from them. And I think that's exactly what we do in medicine as well. We might be looking at, histological slides and then drawing a conclusion from that, but that same kind of methodology is really at play. But what writing does for me is that it allows me to really dwell in the questions of psychiatry. So in the 15-minute encounter, we have to be very efficient. And I know medical education right now talks a lot about efficiency, right? But often thinking deeply is not an efficient process. So what I love about writing is that it gives me an opportunity to take those questions that gnaw on me. So the patients that really stay with me, the presentations that stay with me, the kind of moments that are unsatisfying, right? In medicine are often some of the most interesting moments where you feel sort of unsettled after the fact. And taking time to interrogate those moments and think deeply about them, I think can be incredibly rewarding. And for me, writing is the way that I can do that. So taking time to think about the history of psychiatry, the history of how we've treated people, how that thinking has evolved, to think about how a person might be viewed in a different context, right? In a religious context, in a cultural context, as opposed to just strictly through the lens of medicine. So writing allows for all of this for me, but writing has also offered a real opportunity for advocacy, because I think when many of our patients have experiences that that they themselves might not be able to share. There are beautiful examples of patients who themselves have written about their experience with psychiatric illness. The ones that come to the forefront of my mind are Kay Redfield Jamison's beautiful book, An Unquiet Mind, about her bipolar illness. Ellen Sachs' incredible book, The Center Cannot Hold, about her journey with schizophrenia. There's a beautiful set of poems I love by Jane Kenyon called Having It Out with Melancholy, which is a really profound meditation on depression. So there are these first-person accounts of illness, but I think also we often bear witness to people who perhaps by virtue of their symptomatology or their illness are not always in a position or able to articulate what they're going through. Sometimes that means as a result that the visibility of their struggle is really diminished. And so I think what we have an opportunity to do is share the fact of the suffering that we're witnessing so that people remain really aware of the fact that it exists, right? So we have that role of advocacy. So writing has been my thing. I think others of you are probably writers in the room. You probably have other creative talents and creative means of creative expression. I always say that we admit these incredibly interesting people to medical school, and then we beat the interesting out of them. So I love to look for opportunities where your creativity, your artistry, your unique perspective, maybe you had a totally different job beforehand, can really be an asset as we're tackling these difficult problems and trying to help people in difficult situations. So I hope today will be a little bit like that. We'll have these once vibrant creative corners of your brain that have maybe gotten a little cobwebby, and we'll dive into a little humanities as well. So I have always used, as long as I can remember, I've always used writing as a way to make sense of the world. So that was true for me long before I ever thought about a career in medicine. But when I stepped into the anatomy lab for the very first time, I was confronted with a cadaver and asked to touch and cut open a dead body, as you were also. And of course, I had to write about that experience to make sense of it. So my first book, body of work, was really much more of a kind of meditative work, more of a memoir. It didn't have really an advocacy bent to it at all. But what I didn't understand then when I took on that first project, and what I do understand now, is that my intention in writing all along is often, whether it's about dead bodies or mental illness or now prisons, is really to look where people don't want to look, and to direct their gaze towards something from which we're inclined to avert our eyes. And I understand that better now, that that's partially my project. And I think there is a real opportunity for advocacy there to say to people, no, no, please look here, look at what we're seeing, right? So I work now as an inpatient psychiatrist in a hospital. I love being an inpatient psychiatrist. I work on the intensive treatment units of a freestanding psychiatric hospital. So as you all know, those are like the ICUs of psychiatric hospitals. So the patients that I see are very psychotic, or they're very manic, or they're actively trying to hurt themselves or other people. And the people that I see quite often, as I said, are really suffering. And so the origins of my writing as a form of advocacy kind of came out of the frustration that I felt when people failed to recognize this fundamental aspect of the suffering of people who struggle with mental illness. And it really started, if we can think back to the pre-Trump era, which is so hard to do, but to think back to when the original debates around Obamacare were raging. And it was really a question for some people, whether it was right or not that people should have universal health care. And I was hearing all these conversations on the sidelines of my kids' soccer game, and on the train, commuting different places, about how I was hearing people say, like, it's going to be bad for small business, or it's unnecessary in the first place. And I just felt this enormous disconnect between these conversations and my own clinical experience, where my patients could not access the treatments that they needed. They couldn't afford their medications, and they were ending up in this repetitive cycle of crisis after crisis, which I'm sure you've seen, right? And I tried to think about that in terms of how woefully inadequate our outpatient treatment is that we offer to people, and how many obstacles there are for people to obtain care. And it really felt to me like we were only admitting people and only paying for their care and only making sure they could have access to treatment when they were in states of emergency. And that to me felt akin to saying to someone, we're only going to treat your hypertension if you're having a stroke. So if you're having a stroke, come to the hospital and we'll treat you. But that's the only time that we're going to give you medication for your high blood pressure. It's the only time we're going to make sure that you get care. And so I really started being aware, not just of the fact that people didn't have an understanding of the fact that my patients were suffering, but also that there was this real injustice in terms of medical illness versus psychiatric illness. And that felt really, really wrong to me. So I felt like if the people on the soccer sidelines and in the train car could see what I could see what my patients were going through, then maybe they would think differently. So that's where my second book, Falling into the Fire, grew out of this desire to help people understand the struggles that our patients endure. So that book is really like the 5 or 6 most compelling clinical encounters that I had as a young psychiatrist. Some of them are really described during my residency, to try to give people insight into both the struggles and also the sort of triumphs that our patients show in the face of a great deal of adversity. But working on the units that I do, I see people all the time who come in contact with the criminal justice system. And I have been struck over and over the years that the patients that I see would describe coming in contact with police. They would describe spending time in jail and prisons. And when I would ask them about the circumstances that led to the police encounter or led to their incarceration, over and over again, they would describe circumstances that also were the same as the circumstances that led them to my hospital, right? So somebody's shouting in the Starbucks, or charging through TSA because they feel they have a delusional belief that they need to get on the plane. And in those moments, the police are called, and sometimes people get taken to the hospital, and sometimes they get taken to jail. And those of you who've already worked in emergency rooms see this all the time, right? So that again to me struck me as a point of injustice, and was one of those things that gnawed about me, or that gnawed at me over time. So when I was thinking about what happens to my patients, I know what happens to them when they're in a therapeutic environment like my hospital, but what happens to them when they're in a punitive environment? Then I started working in the jails and prisons. And that was really the impetus for my third book, Waiting for an Echo, The Madness of American Incarceration. And I'm going to read you a couple of sections from that, just to share with you, I think, how my writing went from sort of memoir to the beginnings of advocacy to really saying like, hey, wait a minute, this is not correct. So I'll share with you a couple pieces. And this first section that I'm going to read actually began as a piece in the New England Journal. And I love to say that not to be smug, but to say there's often this real divide between like the scientific world and the literary world, or, research and the humanities. So I feel like there is really a place for crossover and for intersection in these worlds. And I think there is a hunger for a more nuanced understanding in both realms. So I love that this work of literary nonfiction began in like a serious journal. Okay. So part of what has felt very unjust to me that gave rise to this piece is that, as you may know, people with serious mental illness are 16 times more likely to be killed by police than people who are mentally well. And in 2018, of 1,000 people who were killed by police, 25% of those people had mental illness. So this is real. And when I talk to families, families are often so frustrated by the fact that the only way they sometimes feel they can get their loved one's treatment is to call the police in a psychiatric emergency. So you have a police response to a healthcare issue. Okay, so this is, here we go. The trajectory of my patients' lives veers sharply when law enforcement is involved. The earliest decision by police as to whether they belong in jail or the hospital, a decision often made in the moment of the police encounter, may shape the course of the next many years of their lives. As an example, some years ago, I evaluated a man named Henry in the visiting area of a man's jail. Henry was thin and disheveled, and he looked at me with a guarded suspicion when the correctional officer brought him into the room where I was already seated. He was wearing a khaki prison jumpsuit with a white t-shirt underneath, and he smelled as if he had not showered in many days. I immediately noticed that Henry's mouth was in constant motion with the involuntary movements of tardive dyskinesia, a rare but permanent side effect that can be caused by long-term use of antipsychotic medications. Henry had been paranoid at the time of his arrest, and his paranoia had not abated in jail. He was refusing to speak to his attorney, prompting the judge to order a competency evaluation. According to the police report, Henry's legal involvement began when he did not leave the premises of a convenience store after the manager instructed him to do so. Henry hid behind the store's dumpster, refusing to come out when approached by police, and shouting paranoid statements about interrogation tactics and torture and the Connecticut militia. When he finally emerged, Henry was taken to jail. His charges, criminal trespass and resisting arrest, carried a maximum combined sentence of 2 years in prison. But Henry's situation, like that of many psychotic detainees, became far more dire. Henry was prescribed an antipsychotic medication in jail but refused to take it. He might have been paranoid about the pill's safety, or might not have had insight into the fact that he needed treatment. At some point shortly after his arrest, he would not come out of his cell when asked to do so. He was then forced out by COs, a procedure called a cell extraction. Still paranoid, but now with no dumpster to hide behind, Henry resisted, this time by fighting back. In our nation's correctional facilities, detainees who become assaultive are typically sent to administrative segregation, a punitive form of solitary confinement known to exacerbate symptoms of mental illness. Worse still, assaulting a correctional officer is a felony charge, which in Henry's state carries a maximum sentence of 15 years in prison and a $15,000 penalty. If convicted, Henry would spend years in prison, where mentally ill people face a disproportionate risk of being victimized. He would eventually leave prison on probation with legal requirements that would be difficult for him to manage if his symptoms returned, setting him up to incur additional time behind bars. Compare Henry's situation to that of Robert, a psychotic man who caused a similar disturbance in the community. Robert, too, was plagued by paranoid delusions. He had come into contact with police while yelling loudly in the streets of his neighborhood that he was an unwitting experimental subject in a secret government program. But unlike Henry, Robert was admitted to my inpatient unit after police decided to bring him to the hospital rather than to jail. Robert was a large, muscular man in his late 50s with a lumbering gait and erratically mussed white hair. He sat on the periphery of the unit and regarded everyone around him with suspicion. Once he was hospitalized, Robert's paranoia became rooted in the fervent belief that the hospital environment was a front and that he was, in fact, being held in a covert government facility where he was awaiting execution. Like Henry, he refused to take the prescribed antipsychotic medication. As a result, his paranoid symptoms had improved little since admission. One night, new personnel were being trained on the hospital ward. Robert was in the kitchen when a staff member began demonstrating how, in case of an emergency, electronic safety blinds could be activated to cover the wall of windows that separated the kitchen from the rest of the unit. Robert became terrified by the movement of the security blinds and, in the throes of his paranoia, interpreted their closure as a signal. He believed that the unit staff was cordoning off the kitchen in preparation to execute the patients held within. Robert ran out of the kitchen, screaming to the other patients, "Tonight's the night they're going to kill us all." In what he believed was self-defense in a moment of mortal peril, he began attacking the staff. In less than a minute, he assaulted and injured numerous staff members. 2 female mental health workers suffered concussions. A male staff member who intervened and tried to subdue Robert was brought to the floor by him, kicked in the head, and eventually required knee surgery for injuries sustained in the altercation. Despite the severity of the attack, none of the injured workers felt that it was appropriate to press charges. They each offered the same explanation. Robert was clearly ill, and he had been acting out of his illness. He inflicted an enormous amount of damage, but no one perceived him to have done so with malicious intent. As the unit's nursing supervisor said to me in describing Robert's aggression, he was in pure terror. He thought he was fighting for his life. Robert eventually began taking appropriate medications, and his paranoia diminished. After 15 days, he was discharged home with outpatient treatment arranged by the hospital team. Henry, in contrast, remained incarcerated, facing the prospect of spending the next decade and a half of his life in prison. So those kinds of stories, which I was seeing over and over in the research that I was doing, just felt so important to me to get out. And one of the realms in which I work, as Erin mentioned, is that I do perform competency to stand trial evaluations in the jails and prisons. And as you likely know, this is when a judge or a defense attorney has a concern about someone's ability to really understand their charges, understand how court works, work with their attorney. And it's not fair in our justice system for someone who's so mentally ill to go through the legal process without being able to really competently participate in it. So in those moments, a psychiatrist is asked to perform a competency to stand trial evaluation. When I started doing these evaluations, the thing that struck me the most was that if I saw the person by themselves outside of the environment, I often could not distinguish, would not have been able to distinguish between the people I was seeing in jail and the people that I was seeing in the hospital. So they were the same people. We know now why that's true. We know that in the 1950s, 60s, and 70s, when deinstitutionalization happened, which happened, by the way, for good reasons, right? Psychiatric hospitals and in the pre-1960s era were not humane, treatment-oriented places. But when those hospitals were closed, the goal was to have funding and community mental health treatment so people could have that treatment outside the hospital rather than in, but the funding never materialized. So people who had required really intensive levels of care, inpatient care, were suddenly out on the streets without treatment, without food, without jobs, without housing. And this is really when you start seeing what we call the criminalization of mental illness, that mentally ill people are sleeping in doorways and they're sleeping in parks and they're begging for money, and they are susceptible to victimization and they're susceptible to substance use. So when you look at the graphs of what happens during that period of time, the number of people in state hospitals takes a dive, and the number of mentally ill people in jails and prisons just rises. So we've come to really understand that, not as deinstitutionalization, but as trans institutionalization, which I'm sure is a term some of you have heard. So this ill population is really moved just from one institution to another, but it's moved from a therapeutic institution, ostensibly, to a punitive one. And that it remains true today. So what I'm saying is that I'm seeing people who are in a punitive environment who really belong in a therapeutic environment. This is where advocacy comes in, right? So we witness this and we can say that we see exactly what's happening and we believe something different should be occurring. In the current moment, there's lots to talk about around this. And, I mentioned how much more likely people with mental illness are to be killed by police. I think policing is actually an incredibly rich place for us to lend our expertise, because and again, sort of like the example I gave about hypertension, when we think about police being first responders to a psychiatric emergency, that's really different than what happens in a medical emergency, right? If you're in a car accident or you're having a heart attack, the people who arrive are trained clinicians, they're EMTs or paramedics, and they have tools they can stabilize fractures, they can start IVs, they can administer oxygen, they can stop bleeding. They have clinical tools to address the emergency that's occurring. And then they know how to transport someone to the therapeutic environment where they can receive more comprehensive care. That doesn't happen with psychiatric emergencies. We don't, and it could. We could have trained clinicians instead of police who respond to mental health emergencies. We also have to think about what you and I know about how you deal with people who are in psychiatric crisis, and how that really is at odds so often with a police response. So someone who is paranoid, who might be aggressive, who might be self-injurious, really in those moments when tensions are very, very high, we are taught what? We're taught to bring our voices down. We're taught to give people space. We're taught not to corner people, right? To not make them feel trapped. We want to actually ally with them, find a way to collaborate with them. If you're on an inpatient unit and someone gets really, really volatile, you don't want the situation to end in a restraint. What you would like is to be able to de-escalate the situation, give the person some options. Hey, you can go to your room, you can go to the sensory room, you can come talk to me in the conference room, but you can't stay out here doing this, right? So you give options, you lower your voice, you provide a lot of support. That's not what happens in a police encounter, right? The sort of the the commands that happen and the expectation of compliance that happens in a police encounter are really antithetical to what someone can process to de-escalate a psychiatric emergency. And I see this in the prisons all the time as well. And one of the things that I write about in Waiting for an Echo is that there's a fundamental misalignment between someone with mental illness and the environment itself. That correctional officers, like police, have the expectation of compliance. Here are the rules. You follow the rules. If you don't follow the rules, there are consequences. But you and I know that if someone is extremely paranoid, if they're hearing voices or seeing visions, if they're so depressed that they're catatonic, they're not able to follow the rules in the way that they're expected to. And what happens within the prison environment then is that people accumulate more and more punishment. And that punishment often escalates to the point of solitary confinement, which is, of course, kind of the highest punishment that you can get in prison. It's adjudicated entirely within the prison system. So no judge sentences someone to solitary confinement. There's no trial. There's not a defense attorney to keep you out of solitary. It's adjudicated entirely within the system. So if you accumulate a certain number of infractions, that's where you end up. Or if you do something severe enough to end you up there on the first try. And people with mental illness can become really damaged in solitary confinement. Again, I think this is a place where as psychiatrists, we have a lens and a moment to talk about this. Because in this moment of the pandemic, right? Everyone, mentally well people, were coming forward and describing the distress that they were feeling, the escalating anxiety, the senses of isolation, the depression. And so there was this rare moment of empathic connection, and I think during the pandemic, when people began to be able to understand for the first time what we do to people when we isolate them, what we do to people when the degree of inhumanity when you're not allowed to go to someone's wedding that you love, when you can't sit at the bedside of someone who is dying, when you can't visit a loved one in a nursing home, you can't go to the birth of a grandchild, right? We were so acutely aware of how cruel and inhumane that felt. And yet this is what we are doing intentionally to people when we incarcerate them, right? We're stripping them of these support networks. We're stripping them of these human connections. So again, I think there are opportunities for those of us who understand what's required for human flourishing, which really is what psychiatry is about, right? How do we promote flourishing, human flourishing? We can say we know what is required to promote it, and we know what interferes with it. And the practices that we're doing right now in our legal system interfere with human flourishing. I'll give one more example of that really spoke to me in writing the book, and where the title of the book came from. One of the places that I visited and researching the book was a juvenile correction facility in Connecticut. So in a solidly like blue state. This was in a pretty liberal area of America. This is a prison that housed 14 to 20-year-old boys. And when I went into the prison, you know, you're struck right away that these are kids. They're wearing what really could be understood in other circumstances to be scrubs. They look like tan scrubs, but they're of course the prison uniform. When you walk down the hallway, there are lines on the sides of the hallway. And the boys have to stay on one line when they walk through the hallways. And those lines every now and again are interrupted by metal detectors. So they have to stay on that side. And those of us who are not incarcerated there could walk on the other side, on the other line. And when I walked through this facility, and you know, I would see these groups of children, of teenagers walking through, who were incarcerated, first of all, who were absolutely disproportionately brown children, Black children. You know, I didn't count them, but I would estimate easily 90% of the kids that I saw there were kids of color. And then I was taken to see their schoolrooms, see the workshop, see the library. And at the end of the day, I felt a little bit like I had been shown kind of the dog and pony show of the prison, which is not to say that it's not a good thing that there's school in a facility like that, which is not to say that it's not a good thing that those boys have a workshop, but I felt as though it was not being honest about the purpose of the place, and the purpose of the place was punishment. And so, you know, at the end of my day, I was in a group with teachers and psychologists and social workers and prison officials, and I said, what's the worst punishment that a boy can get here? And they said, well, he could be sent to solitary confinement. And I said, for how long? And they said, up to a year. And I thought, again, you and I know the neurodevelopment that occurs in adolescence, right? That integral, essential neurodevelopment that occurs in adolescence. And then you think about a teenager put in a cell where he talks to no one, he's touched by no one, he doesn't have, you know, he already doesn't have the normative school connections, parental connections, family connections, peer connections, but now he's isolated, right? His meals are shoved at him through a slat in the door. And you think what you and I understand about neurodevelopment, that part of it is the impact that sensory deprivation would have on a child, but also how the brain at that stage is just waiting for a roadmap for development, right? It's waiting for cues. And so we know from looking at our studies of institutionally reared kids, kids who've been reared in orphanages, we know the critical pieces that do not occur for kids who do not receive the important human interaction. And the fact that we in this country can do that to children, and that's a legal recourse for us to do, I think, again, is a position for us to say, we dissent, right? And we dissent strongly. So the title of the book actually came from an incident in that prison. I was walking down the hallway of one of the cell blocks, which they completely euphemistically called cottages, which I thought was sort of gross. I was walking by these boys' cell rooms, which are really, really tiny, right? There are bunk beds, and there's a combined sink and toilet at one end and a door at the other end, and there's space just to walk between those things, and that's it. And we walked by one, and one of the boys was standing on his toilet talking to the ceiling. And in the job that I have, I wasn't surprised by that. I thought, I've seen mentally ill people before. I imagined that he was, what we would say would be responding to internal stimuli. And then I continued on down the hallway, and I saw another boy on another toilet doing the exact same thing, at which point I knew that I had misinterpreted what I was seeing, because I've seen all kinds of symptoms of mental illness, but I've never seen the symptoms of psychosis manifest themselves identically in more than one person. So I said to the CEO, "What's he doing?" And the CEO said, "It's a real problem. They've figured out that if they stand on their toilets, they can speak to each other through the vents in the ceiling, and they can have whole conversations that way." And I thought, this is the human pull for connection. This is the symbol of what we're doing to these kids, and the innovation and sort of drive toward survival, toward connection that they were exhibiting, which to me was such a healthy drive, right? Just at any cost to try to figure out how to connect because of that desperate need. So that's where Waiting for an Echo came from. There's a very beautiful quote by the writer Richard Wright, who talks about hurling words into the darkness and waiting for an echo. And if he heard that echo, to throw more words into march and to fight. And so, I think this is where psychiatry and advocacy can align, where we can see practices in our societies, in our communities, that we know are antithetical to mental health, and in lots of situations antithetical to the mental health of our nation's most vulnerable. And we have a chance to speak up about it. So I've talked a lot. I have one passage that I'm going to close with, but I might wait till the end. That's sort of like a launching to aspiring psychiatrists little section from Falling into the Fire. But I might like to pause and just hear about if there are questions. I'm really happy to have people just unmute and ask them themselves, or if you'd like to submit them in the chat, if that's more comfortable for any reason. But you can raise hands, you can do whatever. And if I don't, I'm only seeing with gallery view part of it. So I see Victoria has raised a hand, and you're welcome to go ahead, Victoria. But if, you can also just jump in. Okay. So why don't you start, Victoria, and then I'll let you all kind of self-regulate in terms of the Q&A. Yeah.
Yeah. Wow. Thank you so much, Dr. Montross. That was an amazing talk. Very, very, very moving. One thing I'm wondering is that I have recently become more interested in the work that you're describing. And I feel there's a conflict, but I don't know how real it is because I'm only a medical student, very untrained medical student. This conflict between being in the forensic world, offering these forensic informative things where you have to be somewhat objective, but then having so much emotion in seeing this tragedy and horror that's going on. And how do you balance that or work with that?
Such a good question. And that's really a question for all of psychiatry, I think. And in fact, the piece that I'm going to read at the end really deals with that some. So I'm going to circle back to that at the end. But I think in general, that we as psychiatrists are asked to deal with the suffering of others, right? And so we're going to see difficult things, and we're going to hear difficult stories. And I think one of the things that's wonderful about residency training is that a decent amount of it, if you choose a program that you've asked specifically about, but I think most programs really acknowledge that. So part of the training is, how do you metabolize that in a way where you retain your own health, you retain your own stability, and you retain your own efficacy, which is part of what you're talking about, right? Like, how do you do your job well when you're really horrified by what you're hearing? You know, in the prison environment, there are lots of different things that are going on. The environment is a really horrifying place. People are really suffering. Symptoms are significant. And often people are accused of having done pretty terrible things. And sometimes people will graphically describe to you horrible things that they have done. So I do think there's a part of training that really asks you to learn how to work in an environment like that. And I think, you know, lots of programs encourage people to be in their own therapy or supervision, where you're learning from people who have more experience with you, than more experience than you in situations like that, which I would really encourage as well. I think the irony in this is, I actually think this is true in almost every field of medicine. I think in almost, you know, if you're an internist, you have patients that become gravely ill. If you're an OBGYN, you see catastrophic outcomes sometimes in labor and delivery. Certainly if you're an oncologist, but it's hard to, if you're a dermatologist and you're seeing people who've been terribly burned and you're hearing about their story, such a huge proportion of our patients in any field have endured trauma. So I think one of the benefits of psychiatric training is we own that, right? We go in owning it. Whereas if in your internal medicine training, they might not talk as much about that. So I actually have a lot of faith in the fact that that's a foundational staple of becoming a psychiatrist. So you don't have to feel as an MS3 that you've got that down already. You have a lot of practice ahead of you.
Wonderful, thank you.
Am I going to have to call? Maybe, Sarah, can you call on people so I don't have to?
Yeah.
Stress?
Andrew, you can go ahead. I know you're next.
Thank you. Yeah, thank you so much for talking with us today. So my question for you is, I'm a rising MS4 at the University of Rochester, and I've gotten the opportunity to work in fellowship with someone named Precious Bedell, who's introduced us to a few students, to some formerly incarcerated folks, many of whom are now incarcerated again. There's the cyclical nature of our incarceration system. And this is all involved with a class that's here at the University of Rochester in the undergrad school. It's called Incarceration Nation, and it's taught by some folks who, they are almost, I would say, prison abolitionists is sort of the best way to describe the opinion or the leaning of that class. And I think I've been exposed to a lot of interesting, facets of the incarceration system. What, in your opinion, is the role of punitive, of that impunitive environment? I mean, I know that I think we can all agree it's not ideal for folks with mental illness, and it's not therapeutic. Is that punitive environment, is it helpful for anyone? Is it helpful for people to, how do we deal with this societal phenomenon of, I guess, needing to incarcerate people, or is there an alternative to this? Because I'm wondering if this is a good environment to have in general.
I love this question. Okay, great. Such a good question, Andrew. Thank you. Also completely distracted by your Middlebury flag, because I have a very skewed bias that everyone in my life that I know who has gone to Middlebury is like a interesting, outstanding person and loved it there. So I have a bias just looking at your flag. So the fact that you asked a fabulous question doesn't surprise me at all. Here's what I would say. So lots of different pieces to this. The short answer is, so the answer to should we be treating anyone this way is no. So one of the things that I found in going into jails and prisons was not just that it's a damaging environment for people who are mentally ill, that we also intentionally damage people who are mentally well, and that people come out less functional, less healthy, less socially connected, less ready for employment. You know, we really deteriorate elements of personhood and function in intentional ways in our nation's legal system. So what, right? So what does that mean? It means a couple of things. It means one kind of pragmatic thing and one, I think, more philosophical thing. I'll start with the philosophical thing, which is, I think we have to ask ourselves as a society a question, which is, what are our goals when we incarcerate people? We say that our goals are safety and justice. We act like our goals are suffering and vengeance. We know the metrics of safety and justice, right? Decreased recidivism, safer communities, less violence. Our current practices do not achieve that. Our recidivism rates are very high. Our rates of incarceration and our methods of incarceration are not only shown not to improve, they're not shown to improve any of those metrics. So if we are saying our goals are safety and justice, we're not doing a good job of it. What we do a great job of is suffering and vengeance. So I think either we have to say, look, our goal in America is just to we want you to feel guilty. We want to enact revenge. We would like you to suffer. And that's our tough on crime stance. If you do wrong, that's our goal. And I think we should be honest about that if that's our goal. If that's not our goal, then we have to let go of the drive for suffering and vengeance, because the two things are mutually exclusive. You can't hang on to the desire to punish and damage someone and at the same time say that you're rehabilitating them. Those things are impossible to coexist. So that's the philosophical question, is what do we as a country want? We should decide, and we should be honest about it. If we want safety and justice, which of course I think is the more effective and ethical position, then there are places in the world that are doing a great job of that. So one of the things I researched and waiting for an echo is I went over to Norway and Sweden and looked at how they do things differently. They have much reduced so I went to Norway. Their prison system had a lot of the same problems that ours did: high rates of violence in the 90s. Correctional officers were murdered, detainees were murdered. And they said, this isn't working. Our recidivism rates are high. We have to change it. They completely revamped the system. And the way that they describe it is, we stopped meeting hard with hard and we started meeting hard with soft. And what they mean by that is, we do a needs assessment when you come in to say, like, what was it that led you to be in these circumstances that you committed that crime? And we're going to use the time of the sentence productively to address those issues. So if you need education, you get education. If you need job skills training, you get that. You get mental health treatment or substance abuse treatment, family counseling. We're going to encourage you to spend time with your family. We're going to encourage you to have a job. We're going to make you go grocery shopping and make your own meals so that you don't get infantilized. You have responsibilities, right? You have adult responsibilities, so that when you leave here, you go into the community better able to pick up where you left off and get a job and become a contributing member of society. So there's a lot that I could say about that, and I write about it at length in the book, but we don't need to reinvent the wheel. There are places that are doing it and doing it well, but what it requires is that we shift away from this idea that I don't want to pay for the education. I can't afford for my kid to go to college. Why am I going to pay for a prisoner to be educated, right? We have to let go of the urge for suffering and vengeance if we really want the outcomes we say we want.
Thank you.
Sure.
Thank you. That was a great question and a great response. A lot of things to think about with that. Ryan, I think you were next, and then Tim, you'll be our final question. We have about 10 minutes left.
Thank you so much, Doctor, for your talk today. Your message about how our prospective patients with mental health issues being sent to punitive institutions rather than facilities where they can receive the proper care really resonates with me. of more of the type of facilities that we used to have in the past, minus the inhumanities that occurred, which caused them to be stripped away, so that our prospective patients, these individuals dealing with serious mental health issues, can be transferred to these facilities instead of these punitive facilities, where they can meet the same kind of issues that one poor individual ended up facing with 15 years in jail potentially.
Yeah, Brian, you broke up a little bit on my end, so I think I can infer, I heard most of the question. I think what you were saying is like, so where should people go? What are the answers if they, now that the state hospitals don't exist, if I was hearing you correctly. And I think, there are, again,
Yeah, can
like
we expect more of an emergency in these facilities again?
Is anybody hearing
I'm
that?
just saying, can we expect?
No, shoot, okay.
Ryan, do you mind like putting in the chat what you're trying to ask? You're getting a bit cut off. I'm
Yeah.
sorry.
Good, let's move to Tim.
Okay.
And then we'll come back, or wait, is it already there?
Yeah,
So
it's
should we advocate for the emergency? Okay, great. That's what I thought you were asking. Okay, so I think we need to advocate for a few different things. First of all, is psychiatric beds have been cut and cut and cut and cut over the decades. So, one of the stories that I write about in my book is a man who was dysregulated, charging at people on the waterfront of Portland, Oregon. The police spent 2 hours trying to de-escalate the situation, took the man to the emergency room, and the police commander told me he was discharged before we finished our paperwork. He went right back to the waterfront. The police were called again, and this time they took him to jail. So part of that is on us. We have to fund inpatient psychiatric beds. We have to fund outpatient treatment, right? We have to provide people with the baseline level of treatment so that they're not getting to the place where they're the hypertensive patients having a stroke, right? We have to make sure that they can have access to treat their psychosis in a consistent, steady way. And that's mobile treatment teams, that's community mental health centers, more robust services. So, what we're seeing right now in the pandemic, in our tiny children's hospital in Rhode Island, we have 40 children who are boarding at the medical hospital waiting for psychiatric beds. So 40 kids who are not safe enough to leave the hospital, and there are no beds for them anywhere. So we're having a psychiatric crisis. When that happens to adults, they're often discharged, and they often wind up then in police encounters. So I think we advocate for inpatient facilities. We advocate for funding for our patients. Mm-hmm. Tim.
Hi, I just want to first thank you for this amazing talk. Storytelling is such an important tool, and I think that in psychiatry, it's amazing. Podcasts like Ear Hustle and the books that you suggested are just amazing changes of public opinion, like forces for that. My question kind of relates more to children and adolescents, well, mostly adolescents and young adults who find themselves in prison. You've talked a lot about, there was a section where we talked about like how prison can really affect the neurodevelopment of adolescents in that juvenile facility we're talking about. And you literally said that what is required of human flourishing is not provided. And I wonder at this time where there's been this movement and study of what has been called the school to prison pipeline, and really the prison industrial complex as we see it as mental illness or just like abnormal child behavior in predominantly Brown and Black communities in schools, how that feeds into the prisons. And I wonder what your opinion is about how psychiatrists specifically can interrupt that cycle and how they can play a role in further advocating. I know you talked a lot about advocating for those who are already in prison. I wonder how we can go a step further and prevent those who don't need to even enter that system from entering it.
Yeah. And this goes back in part to Andrew's question too. Part of his question, I think, was also like, should these places even exist, right? And I think one of the things that one of the ways I really come down in that, I don't actually come down entirely on the side of prison abolition, but I do come pretty close. And what I mean by that is, I would say of all of the people that I have evaluated in prisons over my career, a minuscule fraction of them meet the criteria for me as people who cannot safely exist in our communities, who I really believe need to be separated from the communities because they cannot exist in a way that is safe for others. But that is a drop in the bucket compared to the number of people that are incarcerated. So the vast majority of people in my mind should not be incarcerated who are. And for children, that's an even tinier perspective or percentage. So I think we really need to think about what we're doing when we send kids to places like this, and to really invest in alternatives. So one of the things that happens frequently is you talk to people. If you throw out an example like, hey, a kid committed this crime, what should we do? He was involved in a carjacking. It was his first ever carjacking, but he did hold a weapon to this guy's head. He didn't injure him, but the guy was really scared. Carjacking, in the state of California, mandatory minimum for carjacking is 15 years, something like that. But when you ask people, what should we do with this kid? They'll often say, like, what was going on for him? And you say, oh, well, his family just split up and he was struggling in school. He had just moved to a different place. He got in with this bad group of kids. And then you say, what do you think we should do with him? And people say, well, he needs counseling. He needs treatment. He needs he needs family therapy. People have this very humane response and this very correct, nurturing response for children when you tell them individual cases. But when you have politicians who run on tough on crime, mandatory minimum sentences, and when there are scare tactics used that specifically target children of color, then suddenly kids are shunted without the possibility of those interventions into these punitive environments. So I think we really need to assess, why do we incarcerate children and what are the alternatives to that? And that, I think, needs to be a really aggressive interrogation. Yeah, I could say a lot more about that too. So I do want to leave you with one, the psychiatry evangelism, coming full circle. I do want to leave you just with one quick passage. And this, I think, goes to the question that was asked about, like, how do we handle the suffering of our patients? And in this passage, you're going to hear me talking about the idea of abiding with our patients. And I think this term is one that I've really come to love, that abiding isn't necessarily fixing anything. It's not taking action. It's really walking with our patients, being beside them, sitting with them as they're enduring their suffering. And we can't underestimate the power of that. There's poetry in it because I have to bring poetry to things. Okay. So this is from Falling into the Fire. The poet Theodore Rutke endured episodes of severe depression throughout his life. His poem, In a Dark Time, reads in part, "What's madness but nobility of soul at odds with circumstance? The day's on fire. I know the purity of pure despair, my shadow pinned against a sweating wall. That place among the rocks, is it a cave or winding path? The edge is what I have. As a psychiatrist, I hear the stories my patients tell me, noble souls that they are, and learn how their circumstances are at odds with their lives. They come to me bruised and upended, and when they do, the trajectories of their lives seem to them to be at best uncertain, at worst doomed. If I am to abide with these patients, then I must accompany them to that place among the rocks, to the sweating wall. I must face with them the uncertainty of what lies beyond. I must stand at the edge with them and peer over into the fathomless depths." The French philosopher and Christian mystic Simone Weil wrote that to understand affliction, one must accept our total human vulnerability. "I may lose at any moment," she wrote, "through the play of circumstance over which I have no control, anything whatsoever I possess, including those things which are so innately mine that I consider them as being myself. Standing on the edge with my patients, abiding with them, means that I must harbor a true awareness that I too could lose my child through the play of circumstance over which I have no control. I could lose my home, my financial security, my safety. I could lose my mind. Any of us could. A wonderful psychotherapist said to me in the wake of my mother having been diagnosed with breast cancer that we all live beneath a veil of invulnerability. For the most part, we act as if we and our loved ones will live forever. And then there are earth-shaking moments in our lives, a diagnosis, an accident, some unforeseen catastrophe, when the veil is pulled back and we see with clarity that we are all, in fact, perched upon a precipice. Mental illness pierces the veil, and those who suffer from it dwell with their fragility in plain view. My role as a psychiatrist is not to try to repair the veil, but to strengthen my patients so that they can live, so that they can suffer less, so that they can hope. Mary Weatherston is a psychologist who lives in Michigan. She is also a dear friend of mine. More than a decade ago, when I was trying to decide whether to go to medical school to become a psychiatrist, I called her to talk to her about her practice. I worried, I told her, about what it would be like to deal with my patients' misery day in and day out. In retrospect, I think I was asking her how to abide with the suffering of others. Mary shares my love for Northern Michigan and its lakes. Without thinking, she reached to that shared territory for a metaphor. The patients we work with have fallen through the ice in the middle of a frozen lake, she began. My job, your job, should you choose to take this path, is to go out to them, to be with them on the thin ice, and to work with them to get them out of the frigid water. But you must know that if you go out to them on the ice, there's a real danger that you'll fall into. So if you go into this work, you've got to be anchored to the shore. You can reach out one hand to the person in the water, she cautioned, but your other hand needs to have a firm grip on the people and things that connect you to the shore. If you don't, you lose the people who are your patients and you lose yourself. So there's my answer to Victoria's question. Staying anchored to the shore. It's 5:01. I've run a minute over. Thank you for your attentive listening, for the excellent questions. I wish you all the best. Absolutely choose psychiatry. It's such an interesting job. Every day is different. You can do so much good in the world. Good luck to everybody. Thank you.
Thank you. That was an amazing hour. Thank you all. See you
Bye.
later. Bye.
You.